Hi, this is Brian Kim. I want to share with you case number 286 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can continue to refine and hone your technique so that you can provide the very best for your patient. And so you're going to see this is a soft cataract, and I'm going to use a zero ultrasound technique, leveraging manual fracturing concepts and techniques. And I'll be using a single agent Healon GV throughout the entire case, which is great for capsulorhexis and great for soft cataracts. So you can see I'm using the Veritas Vision System. I'm using the cotton tip to steady the eye and use a corneal marker, which will help me to center and size the rhexis. The Healon GV for capsulorhexis is rather different from other viscoelastics. You're going to see that as I do this rhexis here. I make my incision on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some Healon GV. You can see when it comes out somewhat clumpy. This is the left eye. I'm using the Orlock technique, twisting the cannula within the incision to turn the eye down. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. Using the cannula to hold the eye in the Orlock technique, this is my rhexis. So again, these are the Morio microrhexis forceps. I puncture the center, pull down towards me. And look, you don't have to apply any central forces when you're doing the rhexis. You don't have to pull inward, which is interesting with this viscoelastic. It's important that you grab close to the flap edge, the cut edge though, because if you don't, the rhexis will actually turn inward. Because there's not any radialization force, this is not a typical dispersive, you actually have to stay along the plane. You don't have to pull towards the center, which is quite different from using a typical dispersive viscoelastic. You have to pull centrally. Finish off the rhexis. This is the Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, and you can see the lens is beginning to spin. Irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. Placing the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, bringing the instruments together, fracturing the lens in half. That's double chop. Sliding the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, fracturing it against the phaco tip, and that is the cross chop. The first quadrant just kind of fell apart, turning the second heminucleus in front of me, placing the chopper around the lens, another cross chop maneuver, and then fracturing the lens. Performing another cross-chop maneuver and the lens falls apart. Performing it once again and it fractures that quadrant in half. Grabbing it with some vacuum and then crushing it with the chopper, and you see it just disintegrates. And this is the final quadrant, performing another cross-chop maneuver, pulling it centrally toward the phaco tip, and the lens material begins to collapse. So again, with soft lenses, Healon GV is great. You don't have to worry as much about corneal endothelial protection. It's a great single agent for capsulorhexis. Like I said, it provides adequate endothelial corneal protection, and then it's great for placing it in the bag for lens implant placement. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally with the INA handpiece, trying to tease laterally side to side, loosen up that sub-incisional cortex. And with a metal tip, you have to kind of go back to fundamentals. You can't be so haphazard with the INA. You want to be very careful. I'm able to start sub-incisionally, loosen that sub-incisional cortex up. And using foot pedal modulation, you can see the upper right-hand corner. It shows exactly what I'm doing, the foot pedal. And you can see the right side with the aspiration vacuum. It tells you everything I'm doing as far as fluidics is concerned. So the overlay for the Veritas is excellent, and it gives you just a lot of information so that you understand what I'm doing throughout the entire case. So again, peeling from anterior to posterior, loosening all the cortex up. And the cortex is all removed now. Again, using foot pedal modulation and polishing the posterior capsule, and then switching to polish mode, polishing under the rhexis edge, removing the lens epithelial cells underneath the rhexis edge. And this is BSS. I'm pulsing into the subincisional capsule fornix, which is clean. Turn off infusion, and then push the Healon GV to fill the capsular bag. You don't want to be too overly aggressive filling the bag with GV. It does have a little bit of a compressive effect, similar to like a Healon 5. So you want to put some viscoelastic to fill the bag, but also some viscoelastic above the Capsulorhexis edge as well. Sweeping with my sweeper on the left side and then the right side. Placing the Healon GV cannula through my side port incision, placing the injector through the main incision, pushing a little bit of viscoelastic into the bag to inflate it a little bit, because as I inject the lens, some of the viscoelastic comes out. I inject the ZC-BOO single piece acrylic lens into the bag, and then using that same GV cannula, I'm going to disengage the haptics from each other. And then making sure the haptic is disengaged from the optic and that both haptics are in the bag. Going in with the INA handpiece, turning on infusion, getting underneath the lens, removing all the viscoelastic from within the bag. Repositing the lens, sweeping under the rhexis edge, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So again, this is a soft lens case, and I'm using the Healon GV viscoelastic as a single agent throughout the entire case. I'm able to inflate the chamber. For Capsulorhexis, there's excellent anterior capsule compressive effect with this viscoelastic, so rhexis is pretty easy. Because the GV is not the best at coating the corneal endothelium, I'm employing a manual fracturing technique only and using my instruments to crush the soft lens into smaller pieces and essentially performing an aspiration technique of the lens using no ultrasonic energy. You can see all the fluidics on the right side of the screen and how I was able to pulse with the foot pedal to increase that vacuum and emulsify the lens pieces, using the same GV to fill the capsular bag and then injecting the single piece acrylic lens into the bag, and that was the end of the case. So again, Healon GV, versatile viscoelastic throughout every phase of the cataract surgery, which is particularly great for soft lenses when there's no need to use ultrasonic energy. You can primarily use aspiration vacuum to manually fracture these soft lenses. So I hope this was helpful to you, and I thank you for your attention.